was implanted. So we had to explant the inverted IPCL and reimplant a correct IPCL. 2-year follow-up, the patient is stable with a vault of 575 microns. The second patient, this was a case of repeated rotations of the ICLs in the left eye. The visual gain was 6/9 post-op. Despite rotating ICL, redialing the ICL once, there was again another redialing had to be done, and the toric ICL had to be exchanged with a bigger size because of 2 failed attempts. Follow-up of 6 months, there was a stable vault of 435 microns. Case 3, this was a 23rd-year-old female with a good post-op gain of vision. However, on the day 1, the vault was 1120. We observed this eye. 1 month, the vault remained 1250 microns, and 3 months, the vault was 1200 microns. So why such a high vault? Is such a high vault acceptable? These were certain questions that came to our head. For the left eye, we kept her under observation, and for the right eye, we planned after 3 months of the left eye surgery for the right eye, and the ICL sizing we had deliberately reduced. The right eye was 12.1 in size, whereas in the left eye it was 12.6. Case 4, this was a 30-year-old female with an uneventful PHAKIC IOL implantation, good post-op gain. However, in the left eye, as we can see, it was an extremely low vault of 52 microns only. This was almost 1 month in the left eye. So the management was ICL exchange was done with a bigger size. Even on 1-year follow-up, the vault was found to be stable. This was the post-op result, 136 microns. We have kept her under observation, and even after 2 years of follow-up, the vault is stable and there are no signs of any cataract development. So coming to the discussion part, in the first case, there were left eye reverse orientation of PHAKIC IOL was seen. ASOCT was done. ASOCT was the most important modality to diagnose this condition. In the case 2, the left eye, there was rotational instability of the ICL. And we had, in spite of redialing it twice, we had to exchange it for the bigger size. In the case 3, the left eye, there was significantly high vault, which was higher than 1000 mm, and therefore the vault of one eye was kept under observation to decide the size of the ICL in the other eye. In the case 4, the left eye had extremely low vault. In such cases, of course, as I had already mentioned, the low vault, stable, less than 250, stable 1-year post-operatively have been reported, so we kept that under observation. Thank you. All I can say is I can conclude that meticulous and accurate measurements are needed while planning a PHAKIC IOL, and we have to keep them for long follow-ups. That's all.
What were the method you used for calculating the white to white?
Sir, we at our center, obviously we do the IL master and the pentacams. However, we rely on the digital white to white. And digital calipers.
Do you have experience of using the lasso software for getting the predicted vault size? Because
no, sir, we have not used it.
One case you had a low vault and one case you had a high vault. So what could be the cause?
We did all the investigations. We even did, like, everything was the management, the preoperative planning part. We went through all the documents, the gonioscopy, the any histories or that regards to the patient. But we could not come up with any particular reason as to why there was a huge surprise post-operatively. So
actually, we measure the white to white. Actually,
yes.
What measurement we need is the inner sulcus diameter.
Yes, sulcus
so
to sulcus.
Sometimes it may be variable.
Yes,
it may not correspond to white to white. So that time UBM and all will help.
UBM we don't routinely do in every patient, so we can have missed that, sir.